I hope you've all had a great lunch, chance to meet people, catch up, a bit of a relax. We've got a phenomenal afternoon ready for you. As you know, there's been a lot of talk and guidelines and different people thinking about this drug, antiplatelet drug called clopidogrel. Absolutely delighted to have our colleague Wout from the Netherlands, who's come to speak with us. We heard him present his work in Copenhagen at a European meeting a couple of years ago. It's just fantastic, really interesting. So I hope that you find it so. And then we'll move on to Vidya. We'll be talking a little bit about some of the things that are happening in the UK. So Wout, thank you so much.
Thank you. Thank you for the wonderful introduction. And I'm honored to be here to stand here and talk about our experience in the St. Antonius Hospital in the Netherlands. So I've been there a PhD student for almost 4 years now. And I've been busy with personalized care and the personalization of antiplatelet therapy. And today I will talk about our implementation of the genotype-guided strategy in our clinical practice. So I'll first talk about coronary artery disease, some background, why you should treat those patients with clopidogrel or why you should not do that, the genotype-guided treatment, and I will talk about the popular genetics study and our clinical implementation. So to start, an acute coronary syndrome, also known as a myocardial infarction or a heart attack, is caused by a blockage of the artery, mostly due to arteriosclerosis. And in the acute setting, you can treat this with a percutaneous coronary intervention and PCI. But the heart attack is most often caused by rupture of this plaque and acute thrombus formation. And in this thrombus, platelets play a vital role. So you have to inhibit those platelets to prevent thrombosis. So we tackle this platelet party with dual antiplatelet therapy. And that consists with aspirin on the one hand and a P2Y12 inhibitor on the other hand. And it's very important to understand the different P2Y12 inhibitors and the differences between them to understand the genotype-guided therapy. So we have 3 flavors: clopidogrel, prasugrel, and ticagrelor. It's important to know that prasugrel and ticagrelor are the more potent, stronger platelet inhibitors. So in this graph, you see that 100% is full inhibition of all the platelets, and prasugrel, ticagrelor are up to 90%, clopidogrel is around 60-70. And there was a long road to this final treatment of dual antiplatelet therapy. So before 1988, there was no treatment. Then there was the ISIS-2 trial that investigated aspirin comparing to placebo, and aspirin reduced cardiovascular events like myocardial infarction or stroke. So aspirin became the cornerstone of secondary prevention in patients with coronary artery disease. And it was followed with the Capri trial. That study compared clopidogrel with aspirin and saw that clopidogrel was better than aspirin and had a higher reduction of cardiovascular events. But in the CURE trial, following 5 years later, they investigated a new strategy. They combined clopidogrel and aspirin and compared it with aspirin alone and saw that the dual antiplatelet strategy was better. So clopidogrel plus aspirin became the standard of treatment, but a couple of years later, the new P2Y12 inhibitors came into play. And in the Triton study and in the Plato study, they compared prasugrel and ticagrelor to clopidogrel, and in both studies, they saw a reduction of cardiovascular events. So the current European guidelines, they advise to treat every patient with an acute coronary syndrome with aspirin on the one hand and a potent P2Y12 inhibitor on the other hand, so prasugrel or ticagrelor. That is the standard therapy in Europe right now. However, in both trials, in the Plato trial, they also saw an increase of major bleeding due to its higher potency. And also in the Triton study, there was, again, a higher rate of bleeding in the patients treated with that more potent drug. But despite this, the guidelines still have more value for this ischemic risk, and that is why before dual antiplatelet therapy consists with a potent B212 inhibitor. But in the last years, there's a change in strategies in our studies. So this is a graph of all the studies that have been performed in the past 40 years investigating new dual antiplatelet strategies. And first, all the studies were focused on reducing ischemic events. But in the past 10 years, we see that there are multiple studies going on trying to reduce the risk of bleeding. So there's lots of investigation in this field. I want to talk about why there's, in the last few years, we focus on this bleeding risk. So we use newer stents. There's a lot of innovation in the use of stents. We now have second-generation stents with a lower risk for restenosis and a very low risk for stent thrombosis. So the risk for thrombosis has been reduced. But there's increasing evidence that bleeding is not just a side effect, but it has major prognostic implications. And in this figure, you can see that with increasing severity of your bleeding event, the association with mortality increases and is even bigger than having a second myocardial infarction. So bleeding is not just something of a side effect, it's an important prognostic factor. So it's important to reduce this bleeding risk. So with the newer stents and with the new knowledge on this bleeding, there's been a shift from the ischemic risk to the bleeding risk. So what do we know now? Ticagrelor and prasugrel are more effective than clopidogrel, but clopidogrel has a lower bleeding risk. The risk for thrombotic events has decreased, and bleeding events have an important impact on prognosis. So this forms the basis of the genotype-guided therapy. That's why I want to talk about the metabolization of the P212 inhibitors. So ticagrelor is a drug that works directly in every patient and is not influenced with genetic polymorphisms. Prasugrel also has to be metabolized in the liver, but works at every patient in the same manner, so it has comparable efficacy in every patient. But as you may all know, clopidogrel has to be metabolized in the liver in 2 steps, and in both steps, CYP2C19 has the major influence on this metabolization. And it's a quite prevalent polymorphism. So around 30% of the Western population carries loss of function alleles of CYP2C19, leading to a decreased enzyme function. This decreased enzyme function leads to an impaired metabolization of clopidogrel, if you look at the pharmacokinetic response. And this impaired metabolization leads to a diminished platelet inhibition, leading to a higher risk of thrombotic events. And in this study, they saw that with a hazard ratio of 1.5, that you have a 50% higher risk if you are a carrier of such a loss of function allele. If you look at stent thrombosis, the risk is almost 3 times as high. This meta-analysis provides very clear evidence and forms a foundation of the genotype-guided strategy. In this meta-analysis, they combined 7 RCTs, large population, more than 15,000 patients, and in all these patients, the genetic data was known. And they divided this population between 1, patients who were carrier of such a loss of function allele, and 2, patients who were non-carriers. And in both populations, they compared ticagrelor and prasugrel on the one hand with clopidogrel. And indeed, in the patients who are carrier of such a loss of function allele, you see that the risk ratio is 0.7. So patients who were treated with ticagrelor or prasugrel had a lower risk for ischemic events. But in patients who were non-carrier of such a loss of function allele, clopidogrel has a comparable efficacy than the other drugs. That's important to know. So the genotype-guided strategy is based on the following pillars. Clopidogrel is less effective in patients with a CYP2C19 loss of function allele. It is as effective in patients who are non-carriers, and patients with clopidogrel have a lower bleeding risk compared to the other ones. This formed the basis of the popular genetics trial, which has been published in 2019 and was set up by my colleagues in the St. Antonius Hospital. And in the study, they evaluated this genotype-guided de-escalation strategy by randomizing patients between the control arm. The control arm was standard dual antiplatelet therapy, so ticagrelor for everyone. And in the intervention arm, patients were admitted to the hospital. Ticagrelor was started, but then CYP2C19 was tested. Patients who were extensive normal metabolizers were switched to clopidogrel, and the other ones, they remained on ticagrelor. And the goal of this study was to prove that this would lead to a reduced risk of bleeding without an increase in ischemic events. So if we look at the Kaplan-Meier of the primary bleeding outcome, you see in red, is the genotype-guided strategy, indeed that there was a lower risk for bleeding during the first year of follow-up, which was statistically significant, and the reduction was 22%. So they indeed saw this reduction in bleeding that they hoped to see. And they also saw that there was no increase in ischemic events. So this is very good to know that if you treat more patients with clopidogrel, you don't see an increase in ischemic events. So if you look at the therapeutic window of acute coronary syndrome, you could say that on the bleeding side, on the bleeding risk, ticagrelor and prasugrel are high, and on the thrombosis side, clopidogrel is high, and that the genotype-guided therapy is exactly in the middle and the most optimal way to treat these patients. So this was the foundation. Based on these results, we implemented this in our own cardiology ward. And we made a protocol and we trained all personnel, and the protocol said briefly that actually every patient presenting with acute coronary syndrome, with indication for dual antiplatelet therapy, they will first be treated with ticagrelor in the ambulance or at the first day of presentation. We'll test the CYP2C19, and patients who can switch to clopidogrel are switched, and the patients who do not metabolize clopidogrel well, they will continue or ticagrelor. And how did this work? So every patient came onto our coronary care unit with ticagrelor. Then our nurse would draw blood or take a point of care test to assess the CYP2C19 test. They would enter that in the electronic patient files. Then our physician would get a notification with the interpretation of this result. So do you want to add the genetic result to the problem list in EPIC or like a medical history list so that it's mentioned in a discrete field in your patient file, so you can work with that on an algorithm. So our algorithm was like this. You had to be admitted on the cardiology ward, you had to be treated with ticagrelor, and you should have a result of normal metabolization or rapid, ultra-rapid metabolization for clopidogrel. And if these are all true, our physician gets the following pop-up. It is a print screen of our screen in St. Antonius Hospital, so it's in Dutch, but it says that currently this patient is treated with ticagrelor, but it can be safely switched to clopidogrel. Do you want to order this medication orders? And they just have to click on accept. You have the new loading dose and the maintenance dose for clopidogrel. And if you click on accept, the other ones are automatically cancelled, the orders for ticagrelor. And I said that we could test with the point of care test and with the central laboratory. At the beginning of our implementation, we only used the Spartan and currently the genomatics test for the CYP2C19 testing because it was the most quick test. But during our implementation also, because of the costs, we also implemented that patients could be tested via the central laboratory, via blood withdrawal. And in our hospital, this is only measured, analyzed on Monday, Wednesday, and Friday. So we made in our protocol that the acute patients, the ST elevation patients, would be tested with the point of care test, and the other ones, the non-STEMI patients, with the central laboratory. And we also assessed these outcomes in a logistical matter, but also with clinical outcomes. But I will first talk about the logistics. So there were more than 700 patients at this analysis with an acute coronary syndrome with ticagrelor. Around 90% were tested with the point of care test, around 10 via the lab. 65% of those were normal metabolizers and could be switched. 91% of these patients were actually switched to clopidogrel, and 9% was not de-escalated. We saw that the median time to test result from hospital admission to test result was 6 hours, and the time from test result to de-escalation was around 20 hours. And the reasons for no de-escalation, there were multiple reasons, but the most important one was non-compliance by the physician. And this is maybe due to training. We have a lot of new physicians every month. They have to be trained again. So this is the most important reason, but still it's a very small number looking at how many patients we are testing. And looking at the timing of the test results, around 82% of the results were known within 24 hours. And if you divide that between the point-of-care test and the laboratory test, the point-of-care test was way quicker, around 6 hours, while the laboratory test may cost around 2 days, mainly due to the fact that we only analyze it at Monday, Wednesday, and Friday. So that also results in faster results within 24 hours, but also that we saw a higher rate of successful de-escalation in patients with the point-of-care test. So we saw that if you use the point-of-care test, the physician who has seen the first patient on the first day has his result, and you see that that's leading to a more successful de-escalation strategy. So I also want to share with you a quick mathematical sum in which we underline the cost efficacy also of this strategy. So in total, in this analysis, we had tested 855 patients with costs related to these genetic tests. So we had to pay 120,000 euros for getting the genetic results. But due to these results, we could treat 433 patients with clopidogrel instead of ticagrelor. And I don't know what's the situation here in London and the United Kingdom, but in the Netherlands, ticagrelor is way more expensive than clopidogrel. So instead of spending more than 300,000 euros on ticagrelor, we could spend only 10,000 euros on clopidogrel. And on the line, you can see that this was a cost savings of more than 200,000 euros. We also assessed the clinical outcomes of our clinical implementation. We did that by comparing intervention cohort, comparing it to a historical cohort with standard depth. And we have a registry going on in our hospital. It started in 2015, so we have a lot of patients. We were treated since 2015. We implemented this care in 2021, so we have a historical cohort we could compare with the patients later on. The primary outcomes were safety, looking at cardiovascular death, myocardial infarction, and stroke, and efficacy, the bleeding events. And BARC 235 means minor and major bleeding. And just like I said, we had a historical cohort from 2015 to 2021 with almost 5,000 patients. And the intervention cohort had more than 400 patients treated with the same de-escalation strategy I've talked before. So our aim of this analysis was to show that we weren't harming the patients, looking at cardiovascular events, but also to underline that it would lead to a reduction of bleeding. And at this Kaplan-Meier curve, in blue, we have the genotype-guided de-escalation strategy. Looking at cardiovascular events, we indeed see that there's no increase in cardiovascular events, so the implementation is safe. But we also saw a clear reduction in bleeding, almost the half reduction of the bleeding rates, underlining the hypothesis of our implementation and seeing that we actually improving patient care in this matter. We also performed a more detailed cost efficacy analysis based on these results, so including clinical outcomes. We performed a lifetime cost effectiveness analysis with a Markov model, and in a lifetime manner you can see that we would save almost 100,000 euros in costs, but also have an increase in quality adjusted life years. And I don't know how familiar you are with cost effectiveness planes, and I don't know how good you will see it, but The green area is the good area. There you want to be with your results. And almost 19% of our results we recalculated were in this field. So that's underlining the cost efficacy of our implementation. We actually also performed another sensitivity analysis because we know ticagrelor has lost its patent and will have lower costs in the coming years. But in the green line is the current situation, but still, if ticagrelor would be free, the genotype-guided strategy would still be cost-effective due to the benefit in clinical outcomes. So, discussion. A few hospitals have actually implemented this strategy in the Netherlands, and there are several reasons for that. One, availability of the genetic tests. We are the only non-academic hospital in the Netherlands who can test CYP2C19 in such a matter. You have to have a dedicated team for implementation, a professor or a cardiologist who wants to do this, and you have to have the costs related to buy these tests and perform these tests. And hopefully I have already convinced you of the clinical benefit of this strategy. So there's not really a lack of evidence, but there's an abundance of other evidence. I previously shown all the other studies that have been performed for reducing bleeding events. With the red arrow, that is the popular genetics trial, but there are plenty of other trials also investigating other bleeding risk reduction strategies. So due to this abundance, I think that other hospitals maybe implement other strategies in which CYP2C19 is not part of it. So some key points for implementation. You have to have a clear rationale. You have to have a clear scientific base for the things you want to do. And you have to have guidelines which say that you can do that. So otherwise the physicians would never follow this implementation. You have to have adequate training so that the nurses perform the tests adequately, that you get good results. And you have to have the right equipment, so faster results are better. You can also test via the central laboratory, but we saw in our case that point of care is leading to higher implementation rates. You have to have dedicated personnel, so what I talked before, you have to have a cardiologist who wants to implement this in his site. You maybe have to have a PhD student or dedicated nurses who are willing to perform this. The integration into the electronic patient dossier is vital. And I talked about it before. We arranged this with alerts, so leading up to a 91% de-escalation rate was very successful in my opinion, but it's very important to arrange this in your own hospital. You also have to control and reevaluate your implementation, so see where things are going wrong, so you can check those and maybe fix those. And funding reimbursement is one of the most important things, I think, because we started with this implementation by spending our own research money on it. And during the course of our implementation, we were talking with the health insurance, and they were ready to provide the funding for a pilot in our hospital, but there's still no national reimbursement for genetics in the Netherlands. And I will vouch for that, but it's very difficult to change this. And we're busy with the health insurance to change this, but it's a long road. And also briefly want to tackle the ischemic stroke because there was a question from before. And we also do a genotype-guided strategy for the stroke patients in our hospital. And I asked the colleagues of neurology to share with the protocol they used. So this is a standard treatment, leading that every patient with acute stroke is treated with clopidogrel, shortly with aspirin on the side, but after that clopidogrel monotherapy. But also in our hospital, every acute stroke patient is tested for CYP2C19. So it's part of a standard order set. So when you admit a patient with acute stroke, the CYP2C19 testing is already included in that standard order set. Also, when a physician orders clopidogrel in these patients, they get an alert for a reminder to test CYP2C19. However, the neurologist did not include a alert when the test result is available, and they see that sometimes due to this, patients are not switched, which is leading to not 100% implementation, but they're trying to improve this. And also important matter that they only use the central laboratory in this implementation. And their protocol is that extensive metabolizers are just treated with clopidogrel, intermediate metabolizers are treated with a high-dose clopidogrel or aspirin plus dipyridamole, which is not used in cardiology but is still an option in neurology. And poor metabolizers are treated with aspirin plus dipyridamole. So I think I'm already over my time. I've discussed de-escalation, but on the other side there's also escalation. I can talk about it briefly, because escalation is the strategy in which where clopidogrel is standard treatment. You would test for CYP2C19, you would increase to the higher potent drug, ticagrelor, to reduce ischemic events. So de-escalation is to reduce the risk of bleeding. Escalation is to reduce the risk of ischemic events. And this is the case in patients where clopidogrel is standard of therapy, like in neurology, but also in the stable coronary artery disease patients. And de-escalation, popular genetics is the only trial, but in escalation there are multiple trials investigating the strategy in the cardiology field. And if you're in the green side, that is the good side, that is the side in which you have reduced ischemic events. So you see that the escalation strategy leads to lower ischemic events, but the downside is that the only major large RCT in this field was the Taylor PCI, in which the p-value for the primary analysis was just 0.06. It was not statistically significant, and it leads to no mention in the clinical guidelines, which I think it's still a very important sign that you see that also in this large group of patients, the reduction of ischemic events seems notable, and they also performed landmark analysis that there was a significant decrease of ischemic events in the first 90 days. But despite that, it's not standard of therapy of standard of care in cardiology. So these are all the recommendations we have recently given in JAC, but I want to point out the de-escalation strategy because I think there's the best clinical evidence in which I talked before. So patients with the acute coronary syndrome undergoing PCI, you should test them, and if they metabolize clopidogrel, you should de-escalate to clopidogrel. So as a take-home, genotype-guided use of clopidogrel leads to improved outcomes and is cost-effective in patients with acute coronary syndrome. And implementation is feasible, but you have to create the right conditions for a successful implementation. So thank you for your attention.
That's a fantastic presentation. I was sitting in the glow of the fact that I'd invited you. But that's all I managed, but that was really brilliant. Thank you very much. Any questions that spring to mind? We will have an opportunity because we'll be talking for the next little bit about clopidogrel, but anything that springs to mind? Yes, please.
Thank you. I was wondering, have you had any assumptions on test performance? You just had pregnancy comparison between the laboratory and rapid test, and I was wondering if you had any assumptions just comparing them in terms of test performance or accuracy to see if...
Yeah, I understand your question. We didn't compare the results between the Genomatics Cube and the laboratory test because, or you get one or the other. So we don't have the results of both. But we were convinced with already. We also used the Spartan in the popular genetics, so in more than 2,000 patients. In that study, we also did another analysis based on blood. And we were very convinced with those results. So we haven't compared them, but we were convinced that the Genomatics performed well in this manner. Yeah.
And how about the escalation rate you just reported was different, 20% difference between two test results? Have you had any comparison on this?
So yeah, there was a difference indeed between the successful de-escalation by using the different strategies, and that was the comparison we made, and we also shared this with our ward. So you could say, why don't you continue only with the point of care test, because you have higher de-escalation rates, which also will lead to higher cost effectiveness. But what we saw is it's quite interesting that during the implementation, the rate of laboratory use increased. So at first, still the point of care was used in like 80% of the patients, and last years, maybe it's more like 40, 60%. Maybe that's just the experience of the physicians on the ward, that they see and that they know, okay, my patient, the analysis is on Monday, Wednesday, Friday. If I admit this patient Friday evening, I have to perform a point of care test. I should not wait till Monday. So I think that's just learning from the implementation.
We've got some questions here. So Viv, just at the back, and then we'll just round up. Thank you.
So great presentation, and cracking evidence here. But clearly, there are people who are reluctant to take it on board. Whether it's cardiologists or whether it's hospital management, whatever it is, they're not taking it on board. It's difficult to get patients involved because this is an acute event, clearly. But actually, afterwards, when patients are incredibly grateful that they've got through this episode and they've done well, they are the most fantastic ambassadorial workforce for you. And because they know now what good looks like. And actually, if you have patients then going to hospitals and say, do you do this? Because this is best practice. They may be much, much more effective than actually a third of your cardiologists being enthusiastic and 2/3 being doggedly unenthusiastic.
Yeah, I really like your point, and I really think that would help. What I discussed is that I think within the Netherlands, I've done this presentation quite some times in the Netherlands, and I know that the cardiologists understand the results and they would like to do it, but I think the most important thing remains the costs. So we have this registry going on with multiple hospitals in a region, and one of the hospitals is also a cardiologist who did their PhD in this field. And they also want to implement this, but it's only the costs that they don't want to pay, because the cardiologists have to pay the genetic tests out of their own pocket, and the and yeah, that's true. Yeah, that's true. But it's still reluctant to do that. So they want to have funding somewhere else. And I think the health insurers should jump in this void, because it just makes sense.
Final question. Thank you, John.
Thanks for a fantastic presentation. Can I just ask about the consenting process? So has the consenting process changed from when it was embedded in the study to now, when it's more standard of care? How do you actually uptake that conversation?
With the patient, of course, in the study there's informed consent, written informed consent, but now we just implement it in our standard of care. So like you also give a statin to everybody, and you don't ask for, of course you also talk about it, but it's just how we do it in our ward, and we think that's the best care. So it's I know that the nurses on the ward, they have to ask, do you want to open your mouth to perform the tests? But it's not that we have to have written informed consent to perform this test, because it's just in our standard of protocol.
Wonderful. Thank you so much. It was really great.